Hey guys, it's Tamara. I'm back with another video today. Our topic today is going to be about something that all of you, I mean literally all of you, I want to say all of you, all of my subscribers have asked for me to talk about, which is the dangers of medicating trauma symptoms and how do you actually do that? So we're going to focus on that today in today's video. Thank you so much for coming back to my channel, for all your comments and all of your suggestions. They are wonderful. And for those of you who are not subscribed, I encourage you to join the community and go ahead and hit the subscribe button so that we can continue to amplify our message, which is self-knowledge as power and being anchored in knowledge, which is also power. So join us. We'd love to have you. Thank you so much for being here. We are going to talk about the dangers of medicating trauma symptoms, but first I want to define a couple of things for you. So the benefits for you today in this video is that I'm going to define various types of medications. We're going to talk more about medications in a general sense, and then we're going to move on to treatments, and I want to break a couple things down. This is not going to be one video, guys. We're going to have probably about another video or two to kind of help us get a little bit more knowledge about this topic. All right, so let's just go ahead and jump in. So trauma, guys, and I think I may have defined this in some of the videos from last year and some of the videos that I have done recently as well. But trauma is basically any situation that is emotionally and psychologically destabilizing, that you did not have the internal resources, right? The emotional, the psychological, the neurological resources to deal with. And so the challenge outweighed your ability to cope. That is basically the definition of trauma in a general sense. Everybody has interchangeable terms and language for it, but that's basically how I describe it. And I'm going to put it right over here just so that you can have like a visual. All right. So how do you medicate trauma? Well, you know, a lot of clients come to me because I'm internationally certified as a trauma therapist. So they come to me from all over the world and they say, Tamara, you know, can you please treat me for this? And I always say, well, what kind of treatment are you looking for? Because we can do counseling, which is awesome. We can do that. Or we can do medication and counseling together. And a lot of my clients have had very negative experiences with medication. So I'm going to carve out a little bit of time in this video to talk about that. But first, let me go ahead and just define a little bit about the dangers of medicating trauma symptoms. First of all, diagnosis is pretty difficult. And I'm going to post a link to a video that I did on diagnoses in the DSM. But labeling a condition can be very tricky. Trauma symptoms are very tricky. Trauma symptoms can very much look like ADHD, attention deficit hyperactivity disorder. Trauma symptoms can look like oppositional defiant disorder, ODD. Trauma symptoms can also look like obsessive compulsive disorder, right? OCD. Trauma symptoms can also take the form of narcissism. It can also take the form of sociopathic tendencies and behaviors. We can even go so far as to say the trauma symptoms can also look like borderline personality disorder, BPD. So it's really hard to label and diagnose trauma. Really what a trauma therapist is looking for is we are looking for a lack of ability to tolerate things on a daily basis. And I mean flashbacks, hallucinations, possible delusions, right? Believing things that aren't true despite evidence to the contrary. Hallucinations, hearing and seeing things. Reminders popping up into your awareness of a tragedy that you experienced or a trauma. We're also looking for poor functionality. So not taking care of basic needs, not taking care of daily needs like eating, sleeping, clothing yourself appropriately, bathing. Really what a trauma therapist is trying to do is we're trying to take all these symptoms and narrow it down to a very narrow label so that we can tag it post-traumatic stress disorder. Now, post-traumatic stress disorder can either be acute or chronic. Acute is maybe a few weeks to about 6 months. Chronic is between 6 to 12 months, all right? Post-traumatic stress disorder typically includes, and I'm going to put some of the symptoms over here for you, flashbacks, hypervigilance, reminders of the event. You may hear, see, or even smell things that remind you of the event, right? You're easily triggered. You have a heightened startle response. You have an inability to focus. You have inattention. You're irritable. You're depressed. You're anxious, right? You're defensive, right? All of these symptoms over here are post-traumatic stress symptoms. It can be acute, or it can be chronic, all right? when a doctor is looking at the severity of your symptoms, he or she, they're trying to figure out, can you function on a daily basis with these symptoms? When I see you, what I want to know is, can you function on a daily basis with these symptoms? All right. So I usually show my clients a spectrum, and the spectrum is mild, moderate to severe. Okay. Severe is total incapacity to cope. You have a total incapacity to cope. That sounds weird. But yes, you have an incapacity to cope. Moderate is, I can cope sometimes, but I also fall sometimes as well where I can't cope. Mild is, I can cope, but I have some memories that pop up and they're kind of back there, but they don't affect my functionality. So when I look at you on a spectrum, what I'm looking for is the severity of the symptoms and how it interferes with daily life. If I find that the symptoms are in the severe end of the spectrum, then I'm going to recommend medication. If I find that the symptoms are in the moderate to mild part of the spectrum, medication may or may not be needed. All right. And that's where I would bring in a neurologist to get an MRI or a CT scan done. What I would do is bring in a neuropsychologist who can do some neuropsych tests and use some tools that have been proven to identify actual brain changes because of the trauma. All right. So I would pull in a team of people to kind of make some sense out of it for you. Now, when it comes to medication, I'm also looking for a dual diagnosis. A dual diagnosis. And here's the definition, guys, of a dual diagnosis. A dual diagnosis says, okay, I have one disorder, but I also have another. And those two things go together and they influence each other, right? So an example of that would be, you have diabetes, you've had a heart attack, you have some neurological stuff going on, like some epilepsy, but then you also have post-traumatic stress disorder. That's a dual diagnosis, right? They all go together into one, and they can all affect the same parts of the brain and the body, right? So it's kind of hard to tease apart what is what. Is this my epilepsy, or is this post-traumatic stress disorder, or is this a developing psychotic disorder? It's really hard to separate it. So when it's hard to separate a diagnosis, we call it a dual diagnosis, because you're getting two diagnoses and you're being treated for two things at the same time. That's when most doctors and I recommend medication. Okay, so let me just talk a little bit about these medications, and then I'm going to talk about overall treatment, and then I'm going to talk about the dangers of it, and then we'll wrap up, we'll do some other stuff this week, and then we'll jump into the next video. All right, so the medications that are sometimes prescribed for trauma symptoms, and I'm going to give you the general groups, and I'll name a couple of medications you may have heard of. The first group is called SSRIs, all right? SSRIs, selective serotonin reuptake inhibitors. The whole idea behind an SSRI is, number one, less side effects. That's why they were developed. They were developed as a newer generation kind of medication, or a group of medications, with an S, I should say. And the whole idea behind that is we need less side effects, but we need the proficiency and the efficiency, as well as the performance of the medication that we're prescribing, right? We need all of this to work just as well as other medications have worked, and maybe other medications that are stronger or just as strong. So an SSRI might be something like Prozac, or you may have the generic brand, which is fluoxetine. You may have Paxil, which is another SSRI. Those Celexa, that's another one. Cymbalta is more of an antipsychotic, but sometimes it's used for depression. So selective reuptake, selective serotonin reuptake inhibitors are a group of medications that are supposedly less when it comes to side effects, right? They're not going to give you as many side effects as the tricyclic antidepressants. That's the next group, the tricyclic antidepressants. The whole idea behind tricyclics is they work a little bit better. However, they have a lot of side effects. So your tricyclics would be something like imipramine or amitriptyline, right? These are older generation drugs, but they do come with a little bit more side effects. And I'm talking like dry mouth and lower sex drive and, you know, stimulation, that kind of thing. So that's why a lot of doctors will prescribe you an SSRI first. And if that doesn't work, then they'll go to a tricyclic antidepressant. If you have a dual diagnosis like severe or chronic migraine headaches and post-traumatic stress disorder, the doctor may target your migraines with a tricyclic antidepressant like amitriptyline or imipramine, and then target your other symptoms with an SSRI. So they're the experts with that, right? They know how to kind of move around the medications. The next group of medications would be MAOIs, okay? And they are called monoamine oxidase inhibitors. The whole idea behind those drugs is that they are extraordinarily strong. You will get side effects. You might, even have to change your diet. Sometimes with the MAOIs, you have to change your diet. And you have to change very simple parts of your diet. Like you can't eat cheese, you can't drink milk, you can't have dairy, right? Some of those things can actually kill you with this medication in your system. We also have antipsychotic medications, and that would be something like Cymbalta, Haldol. Trazodone is a sleep medication, but it's really strong, or it can be used for sleep, but it's extraordinarily strong. Thorazine is another antipsychotic medication. These medications are typically provided to clients who have hallucinations, and medications have been used in the past, but they weren't helpful. So sometimes antipsychotic medications are prescribed if nothing else has worked, or if you have psychotic symptoms or really, really resistant depression or PTSD. Now, the thing with antipsychotic medications is that you may get tremors, so your hands may shake all the time. You may get a lot of dry mouth, dry throat. You may also experience some psychotic symptoms as well, especially when your body's trying to adjust to the medication. You may also experience some heart palpitations and some other really weird kind of side effects as well. So antipsychotic medications are pretty strong. Monoamine oxidase inhibitors are also strong medications. So I often, I really do talk, when I refer my clients to a psychiatrist, I really do ask the doctor if they could put those on the back burner and focus on, newer medications that don't have those kind of side effects. Now, there's another class or group of drugs known as, I'm trying to think of the acronym, serotonin and norepinephrine reuptake inhibitors. We also have those kind of medications. But we also, in addition to that, have anti-anxiety medications, and those kind of medications are used to kind of reduce the anxiety symptoms. And that would be like, Xanax, Paxil's in there as well, Atarax, Ativan, Buspar, those kind of medications all work on anti-anxiety functions, right? We're trying to reduce the anxiety, hence the word anti, right? We want to get rid of the anxiety. Anti-anxiety medications typically work on the central nervous system, and basically what we're trying to do with that is when we prescribe these kind of medications, we're trying to reduce the central nervous system activity. And we'll talk a little bit about that as well coming up here on next Monday. We're going to talk about the neurological pieces of trauma, so hang in there because I know some of you want to hear that. So yeah, so that's basically it. And there's one more drug too that is also used for anxiety, and that would be propranolol. Sometimes that is used as well. So there's a lot of drugs. It would be about 15 videos for me to talk about each drug, but that's your crash course right there on medication. So what are the dangers? Well, the dangers, one is that sometimes medications can mimic the exact symptoms of post-traumatic stress disorder. And when that happens, it can be really difficult to tease apart, is my PTSD getting worse, or is the medication not working for me? Sometimes medications, primarily the MAOIs and the antipsychotic medications, can actually cause psychotic symptoms. So you can start hearing and seeing things that aren't there. You can have really intense delusions. A lot of drug companies say, well, those are kind of like rare symptoms. And while they may be rare symptoms, they can also be really bothersome symptoms and really dangerous symptoms. When we're talking about the selective serotonin reuptake inhibitors, or the Paxils, the Prozacs or the fluoxetines, those kind of drugs, a red label was applied from the FDA, the Food and Drug Administration, years ago that said, hey, look, these depressants or antidepressant medications are actually creating suicidal thoughts. And there was a lot of controversy about it. Is it the drug causing the suicidal thoughts, or is it the fact that the person feels less depressed and so they have more motivation to kill themselves, right? There was a lot of controversy about that. I'll put an article in the description box for you so that you can read up on that a little bit. But the whole idea behind the red label was we can't prescribe these medications to certain populations, such as adolescents, because it kind of triggers suicidal thoughts. Now, it has triggered suicidal thoughts in other clients as well, or in other populations, I should say, or adults. Now, I have worked with adult clients, and I do periodically when it comes to trauma and grief and loss. And I had one client who took an SSRI when they were extraordinarily suicidal. And it seemed like the depression was making it really hard for them to actually act on their suicidal thoughts. So what they started to do instead was have the thoughts, and they would write them down in a journal and then get rid of the journal, like put it away and not look at it again. The minute they were prescribed fluoxetine at high dose, they became even more suicidal. And it really was overtime work in the hospital that they were in, trying to make sure that they did not kill themselves. And I really do attribute that, and the hospital attributed that as well, to the prescription fluoxetine for this particular individual. It was terrible. So there's one danger, that it can lead to further suicidal thoughts, and it can make things worse. The antipsychotic medications, the danger with that is that it can really lead to some neurological changes in the brain where you can start to exhibit symptoms very similar to Parkinson's disease. It can also have an effect on different parts of the brain where it deadens different parts of the brain. And when I talk about this on Monday, I'm going to focus on that a little bit for you. But it can deaden different parts of the brain. It can cause Parkinson's disease-like symptoms. It can also cause what's known as DTs. It can also cause delirium, right? It can cause other psychotic symptoms that can really make treatment of PTSD really difficult because, again, we can't tease apart what's what. Okay, there have been some medications that have resulted in death, sudden death, and we're talking about the MAOIs, especially if you mix them with different foods that, you know, your system can't tolerate. And in a sense, the MAOIs can turn that particular food into like a poison, and it can really infect the system, and then it can lead to death. So these particular medications are very strong. There's also a sleep medication, and I can't remember what it's called. Oh, I have a million things going through my mind right now, so I can't remember. If any of you remember, please put it down in the comment section below. It's a popular sleep medication. Oh, I can't remember it, but it's a popular sleep medication, and it was causing people to eat and really behave like a zombie. Wake up in the middle of the night and drive places they didn't know that they were. I'll put an article in the description box below for you as well. Some of these medications can do more harm than good. I am not a proponent 100% when it comes to medication. The only time I encourage medication is if my clients really need it. And if the symptoms are on that severe level or on that moderate to severe spectrum where it would be helpful. Other than that, I do not recommend medication the first month or two of counseling unless you really, really need it. So I wanted to talk a little bit about treatments. How about I put that in a video next Monday? Because I think we're way over time at this point, and I don't want it to be overkill for you. Let me know how you feel about all of this stuff down in the comment section below. I welcome your comments, your experiences. And if you haven't subscribed, please go ahead and hit the subscribe button, and I will see you soon. Bye-bye.